So starting back with the thyroid gland, there are only two major hormones from the thyroid glands that you need to worry about. Physically, anatomically, we're going to have this butterfly shape to, oh, you can't see my cursor yet. Can't see that either. What are we doing? What are we doing? Where's it? There we go. Wait, why do I? Okay, well, can you see that? Nope. Look at done. I don't want a pen. It's doing this. Okay, there we go. Alright, so you have this butterfly shape right here. And we're going to call it a right and left lobe, and this middle part is going to be the isthmus. I-S-T-H-M-U-S. This is the isthmus of the thyroid gland right in the middle, connecting the right and left lobe. It does wrap around to the posterior surface of the trachea. And maybe you remember that this is called the thyroid cartilage up here for the larynx. We will cover that when we get to respiratory as well. So the thyroid cartilage is named after the thyroid gland. This is going to be one of those things that gets palpated on physical examinations. When they do this palpation, they're checking for the size and location of your thyroid gland, among other things. There is some histology today. You will need to be able to recognize that this slide in particular, I will not show you a different thyroid slide and make you understand that it's thyroid. I will show you this precise thyroid gland slide and ask that you recognize these as thyroid cells. Histologically within your thyroid, you've got this thing called the follicle, and this is going to be an accumulation of thyroid hormone. And it's these cells immediately around the follicle that secrete that thyroid hormone. So these are called follicular cells, and they release thyroid hormone. If you write T3 or T4, that's acceptable. If you write TH in this class, that is acceptable. So follicular cells secrete into the follicle thyroid hormone. And then you also have other cells in the spaces between the follicles, and those are going to be called parafollicular cells, and they are going to secrete our other hormone of the thyroid gland, and it's going to be called calcitonin. Let me find it. There we go. Parafollicular cells secrete calcitonin, and you've seen calcitonin before. Do you guys remember calcitonin? From what system? From the skeletal system. So calcitonin decreases blood calcium by increasing deposition of calcium into bone. So you've got to consider those two compartments. We're going to go both directions with hormones today. We're going to say calcitonin decreases blood calcium by increasing the amount of calcium stored in bone. Low here, high here. Where's it high, where's it low? So, thyroid gland, two hormones, thyroid hormone, calcitonin. Calcitonin for calcium homeostasis, specifically more calcium in bone, less calcium in blood. And that's really it for the thyroid gland. Obviously, there are very far-reaching consequences for the thyroid gland. If you know about hypothyroidism, if you know about hyperthyroidism, they have massive effects on the metabolism. That's what thyroid hormone is going to do for you. It's going to regulate the rate at which you utilize nutrients and process them into your body. Yes?
This might not have to do with the endocrine system, but when you have calcium deposits on glands, how does that happen?
So calcification can be a response to a number of different things. Calcification can happen not just within glands, it can happen in blood vessels, it can happen in response to trauma. It's usually a pathological condition when it deposits into a random and inappropriate place. It depends on the case. Do you have a specific case of calcified glands that you're thinking about?
Yeah, my dad, when he had Bell's palsy, okay. And then he had calcium deposits on his gland and his throat. I don't know what specific.
If it was thyroid or parathyroid?
I'm not sure.
Okay. I don't know if I have an answer for you off the top of my head for that one, but we can definitely talk about it. And we have seen this before. This is just another slide to show you that elevated thyroid hormones are going to be the trigger for the hypothalamus to decrease its production of TRH, which would decrease its production of TSH. In the absence of elevated thyroid hormone, these would produce more TRH and more TSH. It's just a negative feedback loop, and as long as you can apply your standard rules of negative feedback loops, you'll be fine. On to parathyroid glands. So when you look at the posterior surface of the thyroid gland, you'll find 4 small nodules known as the parathyroid glands. Hence their name, they're around the thyroid. They're the parathyroids. There are 4 of them total, 2 on each side. There are, again, 2 major hormones of the parathyroid gland. You're really only going to worry about one this time, and that is parathyroid hormone. So PTH is the acronym. It also helps regulate calcium. It's going to increase blood calcium by encouraging removal of calcium from the bony matrix. So I want you to be very, very careful with your naming convention. I'm going to draw attention to your names right here. Parathyroid hormone acts against calcitonin. Parathyroid hormone does not act against thyroid hormone. Sometimes in your head you want parathyroid hormone to work in opposition to thyroid hormone because the names sound so similar, but they do not. Calcitonin and parathyroid hormone act in opposition to each other. All right, which one increases blood calcium? Parathyroid hormone, correct. Which one decreases blood calcium? Calcitonin. Which one increases bone deposition? Calcitonin. Which one increases bone reabsorption? Parathyroid hormone, yes. So make sure you're very comfortable with that terminology. Go backwards and forwards with it. Reabsorption of calcium, that calcium ends up in the bloodstream, absolutely. You want to get that straight now because when we get to patho, we're going to have hypothyroidism, hyperthyroidism, hyperparathyroidism, hypoparathyroidism. Yeah, and learning their functions today gets you exactly what all of those conditions are then. It makes it easier. You also have oxyphil cells. We're not going to worry about them. We're going to worry 0 about oxyphil cells. So parathyroid hormone doesn't just increase reabsorption of calcium from bone. It also increases reabsorption of calcium from the kidneys. So calcium that would otherwise be peed out will be reabsorbed by the kidneys. And it also increases absorption of calcium from nutritional sources in the GI tract. So there's actually 3 ways that parathyroid hormone can increase blood calcium beyond just leaching from bones, which is really good. We're happy about that. We don't want to be leaching calcium from our bones all the time. Calcitonin only really has the one way to decrease blood calcium by depositing in the bone. Yes?
If you have osteoporosis, would one of the mechanisms of any sort of medication be to act as an antagonist of parathyroid?
Yes, this will be a target for medications, absolutely, for osteoporosis. This will be something we can, I don't think it's the only mechanism that we can target. A different way to say that would be there are going to be a lot of disease states related to imbalances for these things, related to bones and bone formation or bone deformation. Yeah. It's not to say that this is the only cause of osteoporosis. It's definitely not, but it is related contextually. This is just a table that I wrote up to remind you guys which one's working against which, calcitonin versus parathyroid hormone, and what they do. Okay, questions about parathyroids, thyroids? Notice that by the time we got to the thyroid hormone, we were already 33 slides into it out of 61. So literally that pituitary was like half of it. Okay, adrenal glands, they do get a little bit more complex again. Your adrenal glands, that terminology means above the kidneys. So resting atop your kidneys, you have adrenal glands. There are two portions of your adrenal glands. Your adrenal cortex. Where's the cortex always going to be? Outside, superficial. And then the adrenal medulla is always going to be that deeper structure. If it's more than just a location, they have some histological differences, and they release different types of hormones with different jobs. This is an absolutely beautiful dissection. I want to high-five the person that did this because that is insane. Usually it's very hard to visualize the adrenal glands. They are generally embedded in perirenal fat. So they had to clear fat away and they had to visually differentiate fat from gland, which can be challenging. So this is not a typical good view. This is a fantastic, perfectly clean view. This took a lot of work. All right, histology. I will use this histology image for your lab image options. You do need to be able to recognize the zonas of the cortex and the adrenal medulla from a histological image like this. So it goes like this. From superficial to deep, you have a zona glomerulosa, a zona fasciculata, and a zona reticularis. And deep to those, you have your adrenal medulla. One of the reasons that these are different is your adrenal medulla is actually derived from nervous tissue. It comes from some very, very special embryological tissue called Mineralcorticoids cells that all embryologists are really, really impressed by. So, adrenal cortex goes like this. The zona glomerulosa produces mineralcorticoids such as aldosterone. I'm going to give you the scientific way, and then I'm going to give you the mnemonic device that one of my students shared with me that makes this memorable. The zona fasciculata produces glucocorticoids such as corticosterone. I would like you to write down cortisol as an option here too. Cortisol is pretty well known, memorable. And the zona reticularis produces the gonadotropins. Those are your sex steroid hormones. Those are testosterone and estrogen. So yes, your gonads do produce testosterone or estrogen, depending on your biological sex. Your zona reticularis also produces sex steroid hormones. So after a woman's gone through menopause, her hormone levels drop, but she's still producing sex steroid hormones from the zona reticularis. Both men and women produce both testosterone and estrogen. Obviously, our levels are slightly different. But we have that complementary set because of the zona reticularis. So that was the science way. Here is the fun way. It's slightly dirty. It's not too bad. Salt, sugar, sex. The deeper you go, the better it gets. So aldosterone is going to alter your water retention by altering your sodium levels. So it's actually going to cause you to retain salt, which makes you retain water. Corticosterone, cortisol, is going to affect your sugar and energy balance. The way that you metabolize sugar will be altered by your glucocorticoids. That word gluco in there shows you that it's about sugar. And then, of course, sex is pretty obvious. It's testosterone and estrogen. So mineralcorticoids, here's the structure you're going to learn about in your renal lecture. It's called the nephron. This is the distal convoluted tubule. This is what aldosterone is going to act on. I'd say there's about a 5% chance you'll remember that aldosterone works on the DCT by the time we get there. It's okay if you don't. So aldosterone increases sodium retention and potassium excretion by the kidneys. That is going to increase your blood volume. Later this semester we're going to learn that blood volume is going to increase blood pressure as well. No, I wrote it right there. Increased blood volume increases blood pressure. So that's your salt. Cortisol is going to increase your blood sugar, and it's actually going to suppress your immune system. For a short time, if you're stressed out, it's okay to have less inflammation and a little bit elevated blood sugar. Long term, it's not going to be great for you. And again, gonadotropins, testosterone, and estrogen. Just like we had with our thyroid and parathyroid, there are specific medical conditions associated with having too much or too little of all of these adrenal cortex hormones. So for example, John F. Kennedy had Addison's disease, and that is when you're not secreting enough glucocorticoids.
What does that do?
A lot of things. Yeah, I'm sorry. That's all I got right now. I could tell you about Cushing's a little bit more easily. Cushing's going to be hypersecretion of those long-term stress hormones, and that's going to cause some weight gain. It's going to cause, call it moon face, a bunch of other things. So when I think in general about the adrenal cortex, I think about long-term stress. I think about, you're stressed out for a really long time because you're in nursing school, you're retaining water, you're getting sick all of the time. Those are going to be part of the side effects of having elevated adrenal cortex hormones. Whereas your adrenal medulla, I think of as short-term stress. You're running from a bear. That's your epinephrine and norepinephrine. And that's it. That's all you got to know for adrenal medulla, is epinephrine and norepinephrine. We already know about the sympathetic nervous system. We know epinephrine and norepinephrine are going to increase the activities of the sympathetic nervous system. They're going to do everything from increasing your heart rate and contractility, changing your blood vessel diameters in different places, bronchodilation, increasing your respiratory rate. All of that stuff is going to be related to epinephrine and norepinephrine. I'm going to do one more deeper dive, not something you need to memorize right now, unless it's later on in the slide. Nope, I don't think so. The only difference between norepinephrine and epinephrine is called receptor selectivity. Certain receptors in different regions respond to one versus the other, but they are both increasing sympathetic nervous system activity, or the effects of the sympathetic nervous system. So you're going to have something later on when you get to patho, when you get to pharm, called alpha receptors, beta receptors, alpha 1, alpha 2, alpha 3, beta 1, beta 2. Those are different types of receptors for epinephrine and norepinephrine that affect different tissues in different places. And then you have medications for each of those. So beta blockers, right? Beta 2 blockers. Things like that are going to, it's just locations and effects, and then by blocking them or increasing their activities, we can alter the way that people experience fight or flight or respond to it. Can change blood pressure and heart rate. Yes?
How do both of those affect receptors? Because I was watching a show on Netflix where they're all about Adrenal and stuff, and they were talking about both of those, how they're releasing more, but they're not allowing them to, in a sense, go back in. They're staying in the synapse and everything.
Okay, so what you're talking about right now is reuptake inhibitors. So there are a lot of, what the medications I'm talking about act on the hormones. The medications you're talking about, like Adderall, and I don't know if Adderall is the best example. I think the best example would be something like an SSRI, selective serotonin reuptake inhibitor. The idea is once a neuron has fired neurotransmitters to the synapse, there's 4 ways actually that can go away from the synapse and stop that reaction that the receptors have in the downstream cell or target organ. So by clearing them out, we decrease the activity. A reuptake inhibitor is going to keep more neurotransmitter in the synapse so that it can keep doing that activity. So if you are low, hypothetically, if you're low on serotonin, if we keep serotonin in the synapse for longer, we can have more activity of serotonin even though we didn't produce more serotonin. Does that make sense? Yeah, so that's the mechanism of action for some of those drugs that you're talking about right now. So it's a little bit different than exactly what we're getting at right now. It's not too far off. All of these things act on receptors. Okay, pancreas. Any questions about the adrenal gland? Adrenal cortex, adrenal medulla, difference between them, histological recognition of layers. Okay. Pancreas. That's a big one, right? When we get to patho, we're going to have an entire chapter just on diabetes mellitus. The pancreas we're going to see twice. We're seeing it today in endocrine. We're going to see it again in digestion, because this is a fully glandular organ, but it has cells that are exocrine cells that secrete products into ducts. There's the duct. And it's going to have endocrine cells that secrete hormones into the bloodstream. We're just focusing on the endocrine portion today. So most of the pancreas is pancreatic acini. This is a histological characterization of the form of those exocrine cells. And we'll worry about those when we get to digestive. Today we're worrying about the histological feature known as the pancreatic islets. And if you're old school like I am, they're called islets of Langerhans. I don't know who Langerhans is, but he sounds like a cool guy. So when you're looking at histology, the islets stain pale compared to the acini. So these are the acinar glands that produce digestive secretions. These are the endocrine cells that produce, among other things, insulin. So you actually have 4 types of cells in these pancreatic islets. I do want you to know their names. I want you to know all of the names of all of the things they secrete. I want you to know the functions of glucagon and insulin. Clear? Alpha cells secrete glucagon. Glucagon is going to increase blood sugar. Beta cells secrete insulin. Insulin is going to decrease blood sugar. Remember, it's going to decrease blood sugar by shuttling sugar into cells. If sugar is in cells, it's not in the bloodstream. Those are different compartments. Delta cells secrete somatostatin, and F cells secrete pancreatic polypeptide. We're not worrying about their functions. Obviously, the big star of the show is going to be insulin, right? So when we start to talk about the autoimmune form of diabetes, for example, that's autoimmune destruction of beta cells. But again, you also have alpha cells that are secreting glucagon that act directly in opposition to insulin. So that ends up being a very interesting dynamic, right? Your autoimmune system is, for some reason, not attacking the alpha cells so much as it's attacking the beta cells. Questions about pancreas? We're almost done. Yay. Then we have the blood lecture, so we'll go straight into that. Okay, this is my frenemy. This is the pineal gland. The pineal gland is located in the epithalamus, right where my cursor is right now. I'm covering it. Pineal gland is located in the diencephalon, posterior region. It secretes melatonin. The job of melatonin is to make you sleepy when it's time to be sleepy. So as it gets dark, you're supposed to receive that light information from your retinas, and that's going to send a signal back to your pineal gland. And as it gets darker, it's going to release more melatonin until you go to sleep. And then when it becomes light outside, your melatonin level should drop, and you should be awake. Circadian cycle isn't just about the sleep-wake cycle, it's also like seasonal changes. So if you're a bear and you're going to hibernate for the winter, it's probably going to be moderated by melatonin. And it may actually be involved in onset of puberty just because of that sort of seasonal recognition of timing. Yes, Chris has a question.
Blue light have anything to do?
Yes. The sun, believe it or not, is a blue light. So if your electronics are giving off a blue light, that will impede your ability to release melatonin. That's why more and more computer products are offering blue light filters that make the screen glow orange. I have that on every single one of my electronic devices because I do have a circadian rhythm disorder.
And I have that too, and I'm wondering, like, I have noticed I have, like, slept a little better.
Mm-hmm.
So I didn't know if that actually, like, affected that.
It is exactly what affects that. There's, I lecture on this every year. This is my field. So that retina receiving light information from the outside, a lot of sleep research historically has focused on these external stimuli. There's a German name for it, Zeitgebers. Isn't that great? Sign givers. It's the external stimuli that tell you what time it is. By having electronics that we use around the clock, we are messing with our sign givers, with our Zeitgebers. Yeah.
Is there some kind of connection between blood pressure and melatonin? My daughter's doctor prescribed her blood pressure medication to sleep because the melatonin wasn't working.
I'm going to guess it's off-label, but I don't know what the mechanism of action for that blood pressure medication is.
What about somebody like me that I work at night, so...
Shift work, yes. Shift work absolutely will affect your circadian rhythm and mess with it big time. So using physiological doses of melatonin is how a lot of shift workers get back right onto a correct schedule, or it is a way to artificially manipulate it to be a little bit more functional. So like, oh, I have to go to sleep in a few hours. The trick is going to be to moderate the light environment. So if you're trying to go to sleep and it's bright light shining through the window, that's obviously going to be difficult. And you can use artificial full spectrum UV light to wake yourself up at the incorrect time. It is not ever recommended. There is evidence that every time you get jet lag, there's some permanent neurological damage that happens with that. So shift work is not healthy for anybody. Yes. I think Elena had a little bit more question there. Was there more follow-up? Or are you just going to talk about the drug? Yeah, we can look into that too. Yeah.
So how's it like for me? Like, I could literally lay out in the sun and take a nap.
Obviously, it's different for different people. Yeah. But I don't know why. I don't know why some people are like, I can't. I don't relate. So I have no insight into that. I can't sleep even when it's perfectly dark. Yes.
Will you talk about the computer screen
Yeah.
and like blue light?
Mm-hmm. Sure. I don't know what else you want to hear. The sun is actually blue, believe it or not. That's just the wavelength. It looks, kind of reddish or kind of yellow-orange to us. We draw it with a yellow crayon when we're kids, whatever. But if you're a lighting designer and you want to portray people outside, you use a blue filter to demonstrate that you are actually outside. So really, since the advent of indoor lighting and incandescent lighting, and obviously the onset of technology and computer screens, we've been seeing a rise in sleep disorders and people having a hard time sleeping. So we're generally what people say for sleep hygiene is stop screen use entirely several hours before you go to bed. It actually, that onset of melatonin is gradual. So you actually take, if you're taking artificial melatonin, you take it 3 or 4 hours before bedtime. So if you're cutting off blue light to increase your melatonin more naturally, you should cut your screen time 3 or 4 hours before you want to be asleep. Yeah, it's extensive. It's definitely affecting us as a culture, and the advent of the light filters is very beneficial if you are going to be on your computer until 10 p.m. Yes.
Are there different dosages of melatonin
Mhm.
based on like how?
There are. So if you go to Whole Foods, you're going to find 3 and 5 milligram options. That is not a physiological dose. That is a sedative dose. And this is something that I learned from my 2 sleep specialists, one of which has a PhD, and one of which is a medical doctor. So physiological dose for somebody my size is 1 milligram. If I take 1 milligram, I am not suppressing my body's own ability to produce melatonin at all. remember what we're saying about this homeostasis for the hormonal systems is that if it's very elevated, your glands are going to produce less of it, or your trophic hormones are going to be released less, right? So if you increase your melatonin significantly, your pineal gland will then, in the future, produce less melatonin. If I routinely take a 3 milligram dose, that is a sedative dose, and it makes you sleepier, but then the next night, that 3 milligrams is going to be less effective, and then the next night it's going to be less effective until it's zero effect, and then you stop taking it and your own melatonin levels are very low, and then you have a hard time sleeping after that. So there's a rebound effect. So my doctors, for me, did not recommend a sedative dose nightly. I take a physiological dose nightly, and it's the best my sleep disorder's ever been under control. So 1 milligram, you can buy it online relatively easily. I won't recommend a brand on here, but I'll recommend a brand to you guys if you really want to hear it. If it works. And if I change brands, sometimes it doesn't work because they are entirely unregulated. There is no advantage to getting the melatonergic drugs versus just taking melatonin. It does cross the blood-brain barrier. Yeah, and I asked the guy with the PhD. He's like, well, I can prescribe the melatonergic drug to you if you want. And I just said, is there an advantage or is it just money? He's like, it's just money. He admitted to it. He knew I was going to catch him, so he didn't even try. Yeah.
So I have somewhat tried personal.
Oh, keep going.
Someone that works nights, like, it's good for me to be charting then until, of course, a certain time, like that 4-hour window. Right?
Probably.
That's like the blue.
If you want to stay awake, you get blue light.
Okay.
That's why I make people turn on the light all the time, is keep you guys awake during class. Yeah. Yeah, if you want to stay awake, then get yourself some blue light. Those seasonal affective disorder lights have a really bright blue light, just like 30 minutes in the morning. If you're trying to set yourself to a specific time, like when you first wake up, get that 30 minutes of light from those things. Yeah, the happy lights. Yeah. Okay. That's the pineal gland. I think we're good on melatonin and understanding circadian rhythms. Another fun fact about this, that is not a fun fact, it's a really depressing fact, is that as we age, more and more of our pineal glands are replaced with sand, like actual sand. It's called brain sand. They're called corpora arenacea. It just sort of becomes like this rock-like structure. It's kind of a metabolic waste accumulation thing that happens. And the research on this is not conclusive, but this may be why your grandma gets up at 5 a.m. and starts vacuuming the house. Like, we sleep less and less as we age, and part of that may be our melatonin release. Most of our research on melatonin is not done in humans, it's done on fish, and when we ablate the pineal glands of fish, they can do just fine with just a few pineal gland cells. They don't need a full pineal gland. So it may not be true that that brain sand accumulation, slowly replacing your pineal gland with sand, is not what's causing that, or it could be that fish and humans are different. We don't know.
So what does that do for, like, you or somebody like my daughter who's autistic and has a sleep disorder? As they get older, is that just going to be worse and worse?
Potentially. It's already getting worse for me. No. Mine's under control, except that I've been waking up earlier and earlier, but I think that's partly the 1 milligram of melatonin not keeping me asleep. I'm going to pause this. This is going off. Okay. Thymus is not going to act with the endocrine system. The thymus is a glandular organ. It is entirely glandular. It's going to work with the lymphatic system. We've got a lymphatic lecture coming up later. I'm going to refer to it as the dojo. It's going to be the dojo where some of your white blood cells go to train to be killers. They're not going to be able to train to be killers unless you have an operational thymus. And what this chart right here is indicating is that your thymus gland grows steadily through childhood, and then when you reach adulthood, it declines steadily. And then by the time you're elderly, you have a practically non-functioning thymus, which means you've built up an immune system over the span of your lifetime. But by the time you're elderly, you can no longer train for new viruses. You can no longer learn about newly mutated things, which is why we consider a lot of the elderly population to be essentially immunocompromised. This outermost layer here is fat, so you may still have an appearance of a thymus gland. Generally, it's very hard to spot. I've had anatomists who specialize in dissection try to say that there is no such thing as a thymus in an adult, and that's clearly wrong. But histologically, there's still a few cells. Very few of them will be operational. Yes?
So if there's a child that is immunocompromised, is it more than likely that they either don't have a thymus or...
There are deficiencies for thymus glands that lead to being immunocompromised. I think I teach 3 different variations on physiologically being immunocompromised that are involved with either a genetic deficiency of the thymus, an absent thymus, or you can have a surgical mistake that leads to lacking a thymus.
What if you're splenic?
Asplenic, the spleen is also part of the lymphatic system. It is going to be a site of maturation for some of the cells of the immune system, B lymphocytes. We will talk about that, yeah.
And they're probably missing.
Yeah. So just one part of the cascade in the immune system is missing, and that's really all it takes to be considered immunocompromised, yes.
So things like Crohn's, do that go involved or just
No, Crohn's disease is going to be an inflammatory bowel condition. Yeah, so I think it's inflammation of the lacteals, which are part of the lymphatic system, if I'm remembering correctly off the top of my head. Yep. Okay, finally, cleanup. You've got a couple of other organs that also secrete hormones as another effect. Obviously, ovaries and testes are going to secrete estrogen and testosterone. Testosterone is a type of androgen, so sometimes we say androgens in general. The GI tract is going to release various hormones related to digestion. The heart is going to release something called atriopeptin. So when we get to your heart anatomy and physiology, you are going to learn ANP and BNP, atrionatriuretic peptide and B-type natriuretic peptide. I don't remember what B stands for. The heart releases these hormones to lower blood pressure. And the kidney is going to release EPO, erythropoietin, and that's actually going to increase your rate of red blood cell production. And since we are about to do blood, you're actually going to see that one pretty quick. So for kidney, focus on EPO. For heart, focus on ANP. For GI tract, we're staying vague. Ovaries and testes, think of your sex steroid hormones. And we are done.